Good morning, everyone. My name is Alexandra, and it is truly a blessing and a pleasure to have you here. Welcome to another NCLEX review session. Let's go ahead and get started. As usual, I love to encourage my students. When you're on your journey to study for the NCLEX, it is not easy. And oftentimes, you have to overcome many obstacles to get to where you want to be. And where you want to be is you want to pass the NCLEX, you want to get your nursing license, and you want to become a nurse. I want to encourage you that even though it's not easy, even though it doesn't always feel great, sometimes you're tired, you have other things on your mind, and it is not easy. However, I want to encourage you that it is possible. And all you have to do is put one foot in front of the other. Take it one step at a time, one question at a time, one day at a time. Don't overwhelm yourself. Break it up into little pieces and do it. Do it even if you're tired. Do it if you're happy. Do it if you're sad. Just do it. Even if you tell yourself, you know what, today I'm not feeling good, I'm going to do 5 questions and memorize what I learned from those 5 questions. You did something. Even if you do one question, even if you read one paragraph, even if you come to class for 5 minutes, every day do one thing towards your dream and you will achieve it. And remember, when you can't run, walk. When you can't walk, get on your knees and pray and say, God, help me stand up. You can do it. Our dear Heavenly Father, Lord, thank you so much for today. Thank you for my students. They are a blessing in my life. Bless them. Help them to succeed and pass the NCLEX. The next time they go, Lord, I know you have the victory with their name on it. In Jesus' name, amen. Today, coronary artery disease. I want you to tell me something. Everyone who's on the Zoom, tell me in the chat, true or false? True or false? Is the heart responsible for circulating oxygenated blood that will perfuse the entire body? True or false? Put it in the chat that the heart is responsible for circulating oxygenated blood that will perfuse the entire body. Okay, we have an understanding. That is true. The heart is responsible for circulating that oxygenated blood, right? We've learned over the past couple of weeks that your heart receives deoxygenated blood and it pumps the blood, that deoxygenated blood, to your lungs to get oxygen. Then it receives oxygenated blood back from the lungs into the left side of the heart and sends it out to the aorta to the entire body. Okay, so I have a question. Does the heart need oxygen? Does the heart itself need oxygen to survive? Okay, very good. Yes, it does. The heart is an organ. The heart is made up of tissues, and those tissues are made up of cells, and those cells are made up of organelles, and all of these structures require oxygen to remain viable. Okay, we have an understanding. Now, how does the heart get oxygen? How does the heart muscle, the heart cells, how does it receive oxygen? Because I could say, the organs of the body receive oxygen from the arteries, right? We can say that with confidence, right? But how does the heart stay alive? How does it receive oxygen? Can someone tell me? The coronary arteries. So if we're going to understand coronary artery disease, we first have to understand the significance of the coronary arteries and why they keep you alive. Okay, so these two pictures show you the coronary arteries. So we're very familiar with the blood flow of the heart. Tell me yes or no in the chat if you're very comfortable with the blood flow through the heart. You're very comfortable that deoxygenated blood comes in from the superior and inferior vena cava. It enters into the right atrium through the tricuspid valve, through the right ventricle, to the pulmonic valve, to the pulmonary arteries, to the lungs to get oxygen, back from the lungs into the pulmonary vein, into the left atrium, into the mitral or bicuspid valve, left ventricle, aortic valve, and then out into the aorta, right? Right as the aorta is like it merges with the aortic valve, right as the aorta exits the left ventricle, we have a bifurcation into the right coronary artery and left coronary artery. And from there will diverge the distal right coronary artery, the most popular coronary artery, the left anterior descending. They call this the LAD. This is what perfuses the left ventricle. You can confidently say, I mean, all of the chambers of the heart are important. All four of the chambers of the heart are essential to your survival, but the left ventricle is responsible for contracting with enough force to get oxygenated blood, freshly oxygenated blood, out of the heart and to the body, right? So you can say from a survival standpoint, the left ventricle is the most essential for your survival. So what perfuses the left ventricle? What perfuses the muscle that is going to push oxygenated blood to your body is the LAD, the left anterior descending coronary artery. So you can imagine if somebody had atherosclerosis or fatty plaque buildup and it led to a blockage of blood getting to perfuse the left ventricle, that would cause the left ventricle to become ischemic. Eventually, it could lead to infarction and then a death of that wall of the left ventricle, and then the heart could not pump adequately to get oxygenated blood out. The heart would stop eventually. That would lead to cardiogenic shock and cardiac arrest and maybe asystole, VFib, one of those lethal rhythms, and death if we did not properly treat the patient, right? So that's what we're going to learn about today. So back to the coronary arteries, you have your LAD, okay? You have your circumflex. Circum is like go around. So circumflex, it wraps around the heart, okay? And I know it's not shown here, but you also have coronary veins, okay? But we're talking about coronary artery disease. So these are your coronary arteries. And in this picture, I want you to see just how long the aorta is. The aorta, you have the aortic arch, and this blue line is a cannula that we would use that picture to talk about cardiac cath. So ignore this blue catheter, this bright blue catheter. But look at the aorta, and you can see it has the aortic arch, and it goes in the posterior surface of the heart, and it goes behind the heart, and it goes all the way down the abdomen. So we call this the abdominal aorta. So I just want you to be able to visualize these are your vital organs here: your brain, your heart, your major blood vessels, your lungs, your kidneys. Okay. And I know you don't see the lungs and the kidneys and the brain, but I just always want you to know as a nurse, your vital organs are in the center of your body. Okay. And your vital organs are usually always protected by bone and lots of fat and muscle, right? So your heart is behind your sternum, your lungs are encased by your ribs. Okay. Also, I want you to keep in mind the larger blood vessels are towards the center of your body. And I feel like that's God's perfect way of protecting us from bleeding out. And then as the blood vessels branch away from the center, the blood vessels get smaller and smaller the more distal they are, right? But anyways, you have the aortic arch, you have the abdominal aorta, okay? Also, here is your inferior vena cava. Your inferior vena cava is very long, okay? And then the superior vena cava is at the top, right? Where they would meet in the right atrium and start the blood flow. Okay, so I just want you to see. And here's another picture so you can see the bifurcation of the right coronary artery and left coronary artery. And remember your LAD, okay? So, what do you think? Well, first of all, if I just told you how important the coronary arteries are, I mean, tell me your opinion. Based off of what I just shared with you, do you believe that the coronary arteries are vital to your survival? Yes or no? Honestly, right? I mean, absolutely. I mean, would you want to play any games with the coronary arteries? I mean, would you want any blockages? Would you want them to be too small, or do you want them to be completely open so that they are available to perfuse as much oxygenated blood to the heart muscle as possible? Yeah, like, because that is why your heart muscle is able to pump and relax and pump and relax. That's why your heart can beat. What does the mechanical work for your heart is the heart muscle. And what keeps the heart muscle alive is the coronary arteries. So you don't want any kind of blockages. But guess what? The foods we eat, lack of exercise, smoking, diabetes, poor lifestyle choices lead to this. This is a graphical representation of coronary artery disease. And this does not happen overnight. This is from years and years and years of poor diet choices, of poor lifestyle choices, of not exercising, of not managing high blood pressure, of smoking, of drinking. This is day after day making poor diet choices. This is, I don't want to cook at home. I'm going to go to McDonald's and eat a Big Mac. I'm going to go to Burger King and eat a Whopper. I'm going to eat grill and akra and marinade. I'm going to eat, the fatty oxtail, right? So what keeps the muscle alive? Oxygen. Oxygen. And how does the heart muscle get oxygen? The coronary arteries. So what I want you to understand is the coronary arteries must remain open. They must remain patent. When fatty plaque starts to build up on the inner lining of the coronary arteries, we call that coronary artery disease. What is the problem? What do you need to know for your NCLEX? Okay, the issue with coronary artery disease is it decreases the lumen size of the coronary arteries. Okay, so what is lumen size? So anytime you see the word lumen, we're talking about like a hollow tube, right? Looking at the picture, is it safe to say that an artery is a hollow tube? Okay, so this would be the lumen size. Okay, you see, the lumen size is how open, how available is that tube, how patent. Okay, remember, another word for open in nursing is patent. Okay, so take a look at the green arrow and then take a look at this arrow. Hold on. And you know what? Let me do one better. Hold on. Okay. Take a look at the green arrow and then take a look at the yellow arrow. What happened? What happened to the lumen size? Very good. So you can see that coronary artery disease, one of the major problems is that it decreases the lumen size of the coronary arteries. So that means exactly, so that means that that artery is able to deliver less oxygenated blood to the heart muscle, right? So everything after this decreased lumen size or this partial blockage, everything after, in a way, those tissues are going to suffer. They're not going to receive the amount of oxygenated blood that it should. Okay. Also, do you think your heart has to work harder to bypass this partial blockage? Absolutely. Okay, so write this down. So here's some problems with CAD. Number one, okay, so some problems with CAD. Blockages affect tissue perfusion. So the smaller the lumen size, the less room we have to bring oxygenated blood, the less of a road we have to drive through, right? So kind of like think of your coronary arteries. I think of like a four-lane highway where you're like, oh my gosh, like traffic won't be so horrible because like there's four lanes for us to drive through. We have a lot of room to get to transport these blood vessels, right? But imagine a blockage. Now you only have half a lane or one lane. So blood is going to move through a lot slower. There's a lot more room or risk for traffic jams, right? Also, the smaller the space, the harder your heart has to work to squeeze blood through it. Okay, so that's going to cause an increased burden on the heart. What do you, so when we have a decreased lumen size, we consider that like a vasoconstriction situation. And it's not that the blood vessel got smaller, it's the space, the lumen size, the availability for red blood cells to pass through got smaller. So in a way, it acts like vasoconstriction, and we know that vasoconstriction increases blood pressure, right? So make sure you write that down. Vasoconstriction increases blood pressure, but it's not a true vasoconstriction. It's not like the patient drank coffee. We know coffee causes the blood vessels to constrict and get smaller. It's because of a physical blockage that has decreased the lumen size. But what I want you to understand, and let me use an arrow. Okay, so this reduced lumen size we see with the yellow here, right? It's not true vasoconstriction, but it acts like vasoconstriction because when the blood vessels get smaller, the resistance increases and your heart has to pump harder to overcome that resistance, to squeeze blood through that tiny space. So, what do you think that's going to do to the blood pressure? That's going to increase it. So I just want you to know for your NCLEX, for your nursing career, when there is increased resistance in the blood vessels, okay, first I want you to know the smaller or tighter the blood vessels, the higher the resistance inside the blood vessels, and the heart has to work harder to overcome that. We call that systemic vascular resistance. So the smaller the blood vessels, the higher the systemic vascular resistance, the harder your heart has to work to overcome it. And that increased work increases the blood pressure. Okay, over time your heart have the patient's heart having to work that hard. That's how patients develop hypertension. Now, what happens? The heart is a muscle, yes or no? Yes, the heart is a muscle. Do you think years and years of overworking that the heart will get tired, just like any other muscle? Absolutely, years and years of working harder than it should, right? Because your heart is not the same kind of muscle like like when a guy goes to the gym and lifts muscle and lift weights. That's skeletal muscle because you got three types of muscle, right? You have skeletal muscle, like the ones we build up when we go to the gym. You have smooth muscle, like in your GI tract and around your uterus. And then you have cardiac muscle. Cardiac muscle is not like skeletal muscle. So, years and years of working out, it's not like going to get stronger. It's not the same build as a skeletal muscle. So years and years of overworking itself with hypertension is going to lead to the heart getting tired and giving up. And that's what we call heart failure. So, what I want you to understand in this entire algorithm is that coronary artery disease is what happens when we have fatty plaque buildup in the inner lining of the coronary arteries. This reduces the lumen size. These blockages, which right now we see in the picture a partial blockage, but it can be a total occlusion, total blockage. That is what leads to, heart attack, right? And you can see from the picture, it won't take much. Like all it takes is like one platelet to get stuck there, or a blood clot, or something small to get stuck there, and that patient would have a total occlusion, a total blockage. The other issue with coronary artery disease is the heart has to work harder to overcome that small lumen space because the smaller the lumen size, the higher the systemic vascular resistance, the harder the heart has to work to squeeze blood past that tiny opening and overcome that resistance that increases blood pressure. Over time, the heart working harder than it should, is going to lead to hypertension. And hypertension over time, it fatigues the heart muscle and it contributes to heart failure. So I wanted to take you through that. Also, make sure you know coronary artery disease increases the risk for heart attack, stroke, and death. Also, make sure you know coronary artery disease is a type of heart disease. Okay, so these are things you have to go into NCLEX understanding. So coronary artery disease increases the risk for heart attack, stroke, and death. Okay. All right. So make sure you know that. Also, make sure you know coronary artery disease is what we call heart disease. And heart disease is any condition that affects the heart and blood vessels. So heart disease can be coronary artery disease, it can be heart failure, hypertension, it can be a dysrhythmia, like if your patient has atrial fibrillation, that's heart disease, okay? Um, if they have peripheral vascular disease or peripheral arterial disease, that's heart disease. Anything affecting the heart and the blood vessels. Heart disease is the #1 cause of death in the world. Okay. Hypertension is the silent killer. Can somebody tell me, what does that mean? What do I mean when I say hypertension is a silent killer or the silent killer? When someone has hypertension, like, okay, let's say somebody has a UTI. Somebody has a UTI, they're maybe going to have a fever. Their urine will have a foul odor, maybe, or look cloudy. Maybe it hurts when they pee. When someone has a UTI, most of the time there's going to be some signs, right? Most of the time. What about if a patient has asthma? When they exert themselves or they're around triggers like cold weather or mold, or they exercise, the asthma is triggered and they're going to have wheezing, right? There are some signs to certain appendicitis, the right lower quadrant will hurt. Most diseases and conditions we deal with in nursing, there are some visible or noticeable signs, whether it's subjective or objective, right? But hypertension, somebody's blood pressure could be 180 over 105 and nobody know it unless you check the blood pressure. I mean, they could be looking at you, talking to you, laughing with you. It's your friend at work. You just had lunch together, right? Hypertension, it can go on for years and years and years and nobody know it until, God forbid, the patient has a very bad headache and they go to the emergency room and they check the blood pressure and they say, or God forbid, the patient has a stroke. And that was the only time they ever knew something was wrong with their blood pressure. And if they do survive the stroke, right, the damage is done. Hypertension is a silent killer. That's why every year you need to have your wellness check. You need to see the doctor at least once a year. Have your blood pressure checked. They're going to check your eyes to make sure that there's no hypertensive damage to your retina. They're going to, and also diabetic damage to your retina too. They're going to check your urine test and your kidney test to make sure that your kidneys are not damaged, because hypertension will damage the eyes and the kidneys. It's called end organ damage. We're going to learn about that. There are consequences to not taking care of yourself. And you cannot take care of someone else if you cannot take care of yourself. Remember, it takes a human being to take care of human beings. Just as you would teach this to your patient and tell them how important all of this is, you have to take care of yourself. Go to your annual wellness check, get your blood pressure checked, get your eyes checked, get your kidneys checked every year. Because this is what we would tell our patients. So that way, if there is hypertension, the doctor can catch it and begin to treat it for the patient as soon as possible. What type of diet would you say would contribute to hypertension? Put your answers in the chat. What type of diet would contribute? What type of diet would lead to hypertension? Salty food, high sodium, high fat, fried foods, junk foods, processed foods. Remember, you have to, for you and your patients, the more natural the food, the better. For example, if you eat an apple, that's a whole food. That is food in its natural state. Versus a burger, the meat is processed, the cheese is processed, that bread is processed, right? They say that there's a McDonald's burger, you could leave a McDonald's burger out for 1 year and it would not decay. You ever heard of that? Like they'll say like, oh, you could leave a McDonald's burger out for a whole year and it would still look the same. That's not normal. That's because they put so much preservatives and additives. And all of that, all of those highly processed foods are what contribute to coronary artery disease, hypertension, heart disease, heart attack, stroke, heart failure, death. Okay? So I always spend a lot of time on this topic because I want you to be healthy. I want your patients to be healthy. Okay? What type of lifestyle do you think is associated with high blood pressure? Do you think a lifestyle maybe of high stress? Absolutely. A lifestyle associated with high levels of stress, because remember, we have the fight or flight system, the sympathetic versus the parasympathetic, right? So sympathetic nervous system, that's fight or flight. And that is, the release of epinephrine and norepinephrine. What's the other name for epinephrine? Adrenaline, right? And the release of those hormones from our adrenal glands, which I can't wait to talk about that for module 8. But the release of norepinephrine, epinephrine, also called adrenaline and noradrenaline, the release of those hormones increases our blood pressure. It increases our blood sugar. So being under constant levels of stress leads to high blood pressure and diabetes. I'm talking to you. So I want you to know that for NCLEX. You have to know that for NCLEX. But I want you to know that because I want you to live a long life. And I want you to know that as nurses, it's very easy to tolerate high levels of stress for many, many years at a time. And I know nurses personally who had a heart attack in the parking lot of their job. I want to tell you there's no job worth your life. Yes, nursing naturally comes with an expected level of stress, and you will find the ability to manage it in a healthy way. But if it's coming to a point where your blood pressure is high or you feel unhealthy, if you're working night shift, go to day shift. If you're working too much, there's no paycheck worth your life. One of my colleagues, she she was working so much that her daughter was worried about her. She was a nurse working, I don't know, 5, 6 days a week. And her daughter said, Mom, I would rather you be broke and alive then I have to bury you. And so I'm not going to spend too much time on this because I know we got to get through these diseases for NCLEX, but I want you to live a long and healthy life. And nursing is very stressful, and I've seen too many nurses live for 30 years of high levels of stress, high blood pressure, and it's not worth it. That's what I want to tell you. Remember, you have the power to make your life the way that you want it. So if working 3 days, if it's too much, go to 2 and keep your peace of mind. Remember that. If where the floor you're working on, you've trained, you have tried to get along with everyone, but there's constant stress and stress and stress and stress from the people there, be professional, do your job, and if you feel like, you know what, I don't think this floor is welcoming to me, or if I don't think this floor is good for my level of stress, find another floor. Because remember, nursing, they're always going to find someone else, but you have to stand up for you. Okay? I'm telling you this for a reason. Trust me. All right. Let me get back on topic because I talk a lot. Okay, so this is just another picture to illustrate severe coronary artery disease. Okay, and we do this to ourselves. So we have to stop. And so as you can see, this is a zoom in of this section here of the LAD, the left anterior descending coronary artery. And as you can see, everything below the blockage, the tissue below the blockage, what looks different about that tissue? What looks different here? Appearance wise, it looks different, right? It's turning a little darker. And I'm not going to say, oh my gosh, it's always going to look like that. Probably. But what I'm saying is that picture is trying to show you that the tissues distal to the blockage are ischemic. Does that make sense? Okay. And as you can see here, what has happened to the lumen size? Again, look at the lumen size, right? Look at the lumen size here. We were already in trouble up here, right? That is a lot of fat. Oh my gosh. And then look at the lumen size here. I can't even fit the arrow. So as you can see, as we get down to here, there's, I mean, only one little cell can get through at a time. One little cell, and each red blood cell holds 4 molecules of hemoglobin. Okay. And each hemoglobin, or I'm sorry, each molecule of hemoglobin holds 4 molecules of oxygen. So that little cell squeezing through, do you think that one little cell at a time that's going to perfuse the left ventricle? The left ventricle has the most muscle around it of all of the chambers of the heart, right? So this picture just kind of puts it into perspective. The dangers that patients face with coronary artery disease, also keeping in mind that when we do not write this down, coronary artery disease can lead to ischemia, and ischemia, if left untreated, will lead to infarction. And infarction is an irreversible death of the heart muscle. Okay. All right, coronary artery disease. So make sure you understand the difference between a non-modifiable risk factor and a modifiable risk factors. So coronary artery disease places the patient at risk for hypertension, stroke, and heart attack. Non-modifiable risk factor is something you cannot control. The patient has no control over the gender they were born, their race, their age, or if heart disease runs in their family. They cannot control that. But there are some non-modifiable risk factors that place the patient at higher risk for heart disease. For example, if heart disease runs in their family, they are at more risk or increased risk for heart disease. But the patient cannot control that it runs in their family, right? Versus a modifiable risk factor. These are factors that the patient can control: obesity, poor diet, high sodium intake, tobacco use, and alcohol. Okay? So tell me, as a nurse, which ones do we try to target to educate the patient about lifestyle changes? Are we going to target non-modifiable risk factors or modifiable risk factors? Modifiable, there you go. Perfect, perfect, perfect. Okay. So, modifiable risk factors, make sure you know them. Well, know both non-modifiable and modifiable, but these are definitely NCLEX favorites where maybe they're going to have like a select all that apply. Because the NCLEX wants to know that you understand what is a lifestyle choice that the patient has control to change. So, for example, if they come to the emergency room with chest pain, but we did an EKG, we checked their troponin levels, and they did not have a heart attack, right? So they did not have a heart attack, but we still need to educate them because they came in for chest pain. If the patient tells you that they smoke, now NCLEX wants to know that you understand that that is a modifiable risk factor. We can educate the patient that they need to stop smoking because that will improve their heart health. Because smoking, cigarettes have nicotine. Nicotine is a potent vasoconstrictor. Not just a vasoconstrictor, a potent. It's a powerful vasoconstrictor. So it decreases the lumen size of your arteries, and that makes your heart have to work harder to overcome that systemic vascular resistance. Okay. So, medications, one of the major medications used in the treatment of coronary artery disease are statins. Statins work by lowering your cholesterol. They all end in statin. Common NCLEX favorites include atorvastatin, simvastatin, lovastatin, and rosuvastatin. What is important? You have to memorize this slide and you have to memorize this adverse reaction. If a patient is taking statins and they develop muscle aches, you have to hold the medication and call the healthcare provider. We need to rule out rhabdomyolysis, which could lead to kidney failure. So I'll give you a moment to write that down. This is NCLEX right here, and then we'll continue. All right. So now we're going to learn about chest pain. Okay, so when we have situations like this, okay, so let's say the patient has a, fatty plaque buildup inside the coronary arteries, and they're just laying down all day. The chances of it leading to chest pain are very low because they're not exerting themselves. But what do you think is going to happen when somebody has this type of blockage and they get up to go mow the lawn? When you exert yourself, when you are performing activity, right? Like mowing the lawn, going on a walk, going on a run or something, your heart is going to beat faster, yes or no? Yes. And is it because the more you exert yourself, the more oxygen you need? Yes, the more you exert yourself, the more oxygen you need. So, in response to that need, your heart beats faster, right? So, that's why exercise is associated with an increase in heart rate. Okay, boom. A patient has coronary artery disease. They get up to go mow the lawn. Their heart is beating faster. They need more oxygen. Their heart is beating faster. Their heart is working harder. That is when usually the symptoms of coronary artery disease will finally manifest as chest pain, because these heart muscle cells that are ischemic are going to release troponin. Troponin we can pick up in the blood, you know. Um, but as a result of the lack of oxygen that these heart muscle cells have, they will release lactic acid. Lactic acid is very painful. Okay, if you ever had like a muscle cramp in your leg because you didn't drink enough water, right? It's the same situation where when cells are deprived of oxygen, they release substances and chemicals into the blood that are associated with pain to tell your body that something is wrong. And that's what chest pain is. Chest pain is your heart muscles' way of telling you that, hey, I don't have enough oxygen. I don't know what's going on, but you need to stop what you're doing and look into this. Okay. So that's what we call, some people say angina. I say angina. Okay. So there are three types of angina: stable, unstable, and Prinzmetal's. Okay. And then once we learn about unstable angina, we're going to learn about acute coronary syndrome. Okay, so write it like this. Hold on. Let me do one moment. I'm trying to share. Oh, okay, this, I'm looking for the whiteboard. Okay. I don't know why I keep erasing the arrows, guys. I'm fighting here. But I don't know why when I studied it like this, when I was first learning about this really helped me. Okay. Can everyone see the screen fully of what I've written? Okay. So take your time, write this, memorize it. You have to be very strong in these conditions, and this is what we're about to talk about right now. But you have to be very strong and confident in what all of these mean, how they manifest, and how you treat them. All right, so you've got three types of angina: stable, unstable, and Prinzmetal's. And then we have a progression where once the patient has unstable angina, they have walked into a spectrum called acute coronary syndrome. So, acute coronary syndrome is a medical emergency because the risk of death is extremely high. So, unstable angina versus STEMI versus NSTEMI. Okay, and how we're going to know the difference is we're going to do an EKG. We're going to do troponin level. Also, how we're going to know is does the chest pain go away with rest? And so we're going to talk about that. All right, let's go back to the PowerPoint. Okay, types of angina: stable, unstable, Prinzmetal's. So stable, write this down. Stable angina, the chest pain goes away when they stop the activity. So whatever they were doing that started the chest pain, if once they stop, they have a seat, they lay down, they feel better, that's what we call stable angina. So stable exertional angina or stable angina is a fixed blockage of the coronary artery from cholesterol buildup. Symptoms occur predictably at a certain heart workload, so at a certain level of activity, and it goes away with rest. That's what you have to understand. Over time, blockages get worse and symptoms occur earlier. So maybe he could mow the lawn for 15 or 20 minutes and then he would get chest pain. But when he sits down, it gets better to eventually, if he doesn't make the proper lifestyle changes or we don't identify what's going on and treat it, then it's going to be like he's just mowing the lawn for 5 minutes and he gets chest pain. And now when he sits down, it doesn't go away. Now that's unstable angina, right? Guys, give me one moment. I apologize. Please. All right, so you've got stable angina. Next up is unstable. So, unstable, it occurs when a previously stable blockage now becomes unstable. And it actually begins to attract clotting factors. It actually begins to attract components of the blood that can clump together and form a thrombus, which would block blood flow. Symptoms come and go, and it's no longer just with activity. It can even be at rest, the patient will begin to develop chest pain. This is very unpredictable. So write this down. Unstable equals unpredictable. And it's very dangerous. And that's why unstable angina is part of acute coronary syndrome, which is an emergency. But really, all chest pain is an emergency. Don't get me wrong, right? But which one would you be more concerned about? Let's say it's you and an LPN. You're the RN and you're working with the LPN, and you have two patients who've come in for chest pain. One tells you that now that they're sitting down and resting, the chest pain has gone away, and the other tells you they sat down and been resting for 30 minutes, but the chest pain has only gotten worse. Which one are you more concerned about? The first one or the second one? The second one, right? And which one would you assign for the LPN to go take their vitals or delegate? The first one, exactly. So just keeping that in mind, right? Stable angina is predictable. It will predictably go away with rest. However, if we do not treat it over time, it can deteriorate to unstable angina. Then we have Prince-Meadows. This is a vasospastic angina. There's no underlying blockage, but what happens is the vessel wall clamps down and squeezes off blood flow. It's unpredictable and it can lead to heart attack. So Prince-Meadows is because of a vasospasm. Okay. So treatments. So stable angina, we're going to give nitrates, beta blockers, calcium channel blockers, renazoline, and ivabradine. Okay. Prince-Meadows angina, we use calcium channel blockers and nitrates. Unstable angina, we're going to talk about that. So take a picture of this because we don't have a lot of time for you to write everything down, but this is something you definitely want to come back and watch the recording as you're building your notes for this. So unstable angina, this is, part of that medical emergency IV, vital signs, MONA, EKG, troponin levels times 3, and a possible cardiac cath to perform percutaneous coronary intervention. So for unstable angina, write that down. All right, nitrates. So nitrates can help to prevent and treat angina by causing vasodilation, reducing blood flow to the heart, and helping to reduce the work of the heart. So write this down. Nitrates are vasodilators and reduce the work of the heart. If you can memorize that for NCLEX, you are good to go. And excuse me, I have a spelling error there that is embarrassing, but I have fixed it. Okay, one moment. Okay. So write that down. Nitrates cause vasodilation and reduce the work of the heart. The other major thing to make sure you know about nitrates for NCLEX is that they drop blood pressure. So make that 3 things to memorize. Nitrates cause vasodilation, they reduce the work of the heart, and they drop blood pressure. So your examples, the 3 examples that I would know for NCLEX are nitroglycerin and isosorbide dinitrate and isosorbate 5 mononitrate. Okay. But nitroglycerin is the most popular one. Like 95% chance, 90 to 95% chance you see that on the NCLEX. There's 3 different routes we can give nitrates: sublingual, transdermal, and IV. Obviously, sublingual is an NCLEX favorite, making sure that the patient shouldn't like swallow it or chew it. You put it under their tongue and it will dissolve. And oh my gosh, IV nitroglycerin, now that will powerful antihypertensive. Make sure before you give a nitrate, you check the blood pressure. Okay. Like we said, number 1 priority before giving a nitrate is to check blood pressure because it can lead to hypotension. I mean, I have seen it and it is ridiculous how fast or how effective nitroglycerin is in dropping blood pressure. Okay, beta blockers. Beta blockers are used in the treatment of angina. They help lower heart rate, blood pressure, and the force of cardiac contractions, reducing myocardial oxygen demand. Okay, a patient has chest pain because they got up to go mow the lawn and they're pushing that lawnmower. It's 98 degrees out, the sun is out, it's hot, they're sweating, their heart is beating fast, their blood pressure is high. When a patient has chest pain in that situation, the demand being placed on the heart is high. So the heart tries to rise to the occasion and meet that demand by working harder. If we give a patient in that situation a beta blocker, we're decreasing that demand. We're decreasing how much oxygen the heart is asking for. So therefore the heart can work less. Okay? So just memorize the first sentence. Beta blockers help lower heart rate, blood pressure, the force of cardiac contractions, and they reduce myocardial oxygen demand. Also, it's very helpful to keep in mind that beta blockers are cardioprotective. They help prevent second heart attacks and help improve the survival rate from a heart attack. Common NCLEX examples are metoprolol, propranolol, and bisoprolol. Okay, NCLEX favorites. But you know, anytime it ends in LOL, it's a beta blocker. The number one priority. What are your two things that you're going to check before you give a beta blocker? Heart rate and blood pressure. Beautiful, guys. You see, you guys are going to pass the NCLEX. So number one priority is to check both the heart rate and the blood pressure because beta blockers drop both. So remember, write this down. Beta blockers both. Okay, beta blockers both. They drop both. Next up is calcium channel blockers. Calcium channel blockers work by preventing calcium from entering the myocardial cells, causing the heart muscle to relax and vasodilate. And remember, vasoconstriction makes the heart work more. Vasodilation makes the heart work less. So in situations with chest pain and blockages, we want the heart to have less workload on it. And vasodilation will achieve that. Examples, amlodipine, diltiazem, and verapamil. Number one priority before giving a calcium channel blocker would be to also check blood pressure because a calcium channel blocker is a blood pressure medication. Okay, other medications. Ranolazine is a sodium channel blocker and it is used as a treatment for chronic angina. It can prolong a part called like the QTC interval, which can lead to torsades de pointes, which can lead to VFib. It is often used for patients with symptoms that persist even with preferred anti-anginal treatments. Next up is ivabradine. It's a sinus node inhibitor, and it is also used in the treatment of chronic angina, and it is used for patients who cannot tolerate beta blockers, or it can be taken with beta blockers if the beta blockers are ineffective. So I know I'm zooming through this, but just go through the recording because this is something that is going to take you a few times to understand. Okay, we're going to go to the next slide actually. We did this already. Okay, coronary artery, acute coronary syndrome. Acute coronary syndrome includes unstable angina, ST segment elevation MI, and non-ST segment elevation MI. So, can somebody tell me what is the definition of unstable angina? Can somebody tell me in simple terms what is the definition of unstable angina? So very good. Unstable angina is when the chest pain does not go away with rest, right? And it's unpredictable. And it can lead to the formation of blood clots. Very good. Okay. So we spoke about the ST segment before in previous classes because now we know what unstable angina is, right? And we know that it's part of acute coronary syndrome because it's unpredictable. We talked a little bit about ST segment elevation MI and non-ST segment elevation MI. What did we learn about the ST segment in the previous classes? What is the ST segment supposed to look like? The ST segment is supposed to be isoelectric, right? What does isoelectric mean? Very good. What does isoelectric mean? Flat, right? So the ST segment, remember we learned last class is supposed to be flat. So when we have an elevation, we call that ST segment elevation. And then when it's too low, we call that ST segment depression. So we learned what the elevation and depression mean. We learned that ST segment depression indicates hypoxia or ischemia, right? ST segment depression indicates ischemia. ST segment elevation indicates what? Infarction. Very good. So if you did not remember that from the last class, make sure you write that down, that ST segment depression indicates ischemia. ST segment elevation indicates infarction. Okay, unstable angina, we know that it's chest pain resulting from myocardial ischemia. Make sure you know for NCLEX and nursing, right? Number one priority for a patient who comes in with chest pain is to provide pain relief. We're going to do everything else, right? But your number one priority as a nurse for a patient with chest pain is to relieve the pain. And I want to ask you something. Unstable angina is chest pain, correct? Yes or no? And come on, you guys are taking too long to answer. Okay, thank you. Unstable angina is chest pain. I want to ask you something. Does chest pain automatically mean the patient is having a heart attack? There you go. Very good. If you can think like that, you will make good decisions on NCLEX. Very good. So keep those principles in mind. Unstable angina is chest pain. Your number one priority as a nurse is to treat the chest pain. We're going to take care of everything else. Give all the meds we need to give, right? Check all the labs we need to check. Do an EKG, all of that. But we need to provide pain relief. Also, keep in mind, just because a patient has angina or chest pain, it does not mean they're having a heart attack. We have to rule out a heart attack. And that's why we're going to do the EKG and look at the ST segment so that if it's depressed, it's end-stemming. If it's elevated, it's stemming. That's why we're going to check blood work for troponin level, okay? Assessment, they might have substernal, so underneath the sternum, crushing, squeezing pain, pain that radiates to the back, jaw, shoulders, or down the left arm, pain that doesn't get worse when they breathe, shortness of breath, pallor, sweating, palpitations, tachycardia, dizziness, hypotension. Also, make sure you know the differences, okay? So one of our classmates asked, what causes the pain? What causes the pain? Let me go back to that slide. Hold on. I'm going to show you a picture that helps me to get it. What causes the pain with chest pain is there is a decrease in the lumen size, and so not a lot of red blood cells can get through and oxygenate the tissue. So the tissues underneath the partial or total blockage become ischemic, and they release lactic acid. And lactic acid, it's irritating to the nerves, and you feel it as pain. Okay, so chest pain is your heart muscle saying, I'm not getting enough oxygen. You need to do something about this. Does that make sense? Okay. The other thing I want you to know about chest pain is that men and women may have different types of symptoms. Men usually have the typical chest pain symptoms, where like they feel like an elephant is sitting on their chest, a crushing chest pain radiating down the arm, especially like the left arm, back or shoulder. So men usually have the classic, typical chest pain symptoms. Women are more likely to have atypical symptoms, such as GI, nausea, vomiting, upset stomach, indigestion, flu-like symptoms, tired feeling, fatigue. Okay. So one of our classmates asked, why should I give the pain pill, not oxygen? So remember, I said we're going to do all of that and we're going to learn the treatments. We're going to give all of the important treatments that we need to give for chest pain. However, we are going to prioritize to first treat the pain and then do everything else. Does that make sense? Okay, so what I want you to get in this slide is that men have typical chest pain symptoms. Women tend to have atypical. And so that's why women are very likely to die from a heart attack because we often don't have the typical chest pain symptoms. So we think, oh, we just had nausea or vomiting, or we just have the flu. We're just really tired, when in reality, the woman could be having a heart attack. So I'm not saying that anytime you feel that you have the flu, that you need to go to the emergency room, but get yourself checked out. And if the symptoms aren't going away, get yourself checked out. Make an appointment with your primary care doctor. And if you just don't feel right and something, you feel in your heart, go to the emergency room. Okay, so for this, I'm going to show you something. One moment. Give me one moment. All right, guys. I'm going to share something on the screen and write this down, and then we're going to talk about it. All right, everyone. Thank you so much for your patience. Okay, so we can see diagnosis of chest pain. We're going to do, a quick little history and physical. When they come in for chest pain, you want to know what is happening, right? Because if they had chest pain from mowing the lawn, or if they had chest pain after doing cocaine, right, we can kind of get an understanding of what's going on. So just asking some questions, symptom pattern, finding out any risk factors, doing a 12 lead EKG, looking for any ischemic changes. Remember, ischemia is associated with ST depression, whereas infarction would be associated with ST elevation. We're going to do blood work for cardiac biomarkers, especially troponin. If it's angina, the troponin level would be normal, but if it's myocardial infarction, the troponin level would be elevated. Tell me yes in the chat if that makes sense. Tell me yes or no in the chat if that makes sense. If it's just angina, the troponin levels will be normal. But if it's a myocardial infarction, the troponin levels would be elevated. Okay. Also, if it's chest pain, we're going to do either an exercise or pharmacological stress test, depending on what the healthcare provider wants to do, to see if the patient is having angina as a result of coronary artery disease. Okay. Echocardiogram, which is an ultrasound of the heart. This is going to allow the doctor to assess the ejection fraction, check for heart failure, and check for any valve issues or issues with wall motion. Like again, when the tissues become ischemic and that wall of the heart cannot move because of ischemia and infarction, these are things that would be able to be picked up on the echocardiogram. Coronary angiography, which is also called a cardiac cath, this is the gold standard in the diagnosis of chest pain, and it is definitive in the testing for coronary artery blockages. All right. Okay, so nursing interventions for chest pain vitals, EKG, assess and document chest pain. We're going to give aspirin, we're going to give nitroglycerin. So MONA is outdated now, and we're going to talk about it. So the acronym MONA stands for morphine, oxygen, nitroglycerin, and aspirin, and it was historically taught as the standard initial treatment for angina and acute coronary syndromes. However, it is now considered outdated because evidence-based guidelines, like from the American Heart Association, have revised the role and order of these interventions. So oxygen is no longer routinely given unless the patient is hypoxemic. So if their O2 saturation is less than 90%, then we give oxygen, okay? For NCLEX, for NCLEX, if the oxygen level is less than 95, you can give the oxygen. Okay, why is oxygen no longer routinely given unless the patient is hypoxic? It's because unnecessary oxygen can cause coronary vasoconstriction and worsen outcomes. Okay, so this, you can verify this on the American Heart Association website, but I promise I wouldn't lead you wrong because again, I really care about you and your future. So this is the most recent evidence. Morphine is used cautiously now because it can mask symptoms, lower blood pressure, and it is linked with increased mortality in some acute coronary syndrome studies. It is now reserved for severe unrelieved chest pain only. Nitroglycerin and aspirin remain the first line treatments. Aspirin reduces clot formation, while nitroglycerin relieves ischemic pain and it improves perfusion. Okay, so please keep that in mind. So of the MONA, we're just doing the NA, we're just doing the NA, the nitroglycerin and the aspirin. The nitroglycerin will relieve the chest pain, and it will also improve perfusion by reducing the workload of the heart, and aspirin is going to reduce clot formation. Okay, so as a nurse, we're going to do vitals, EKG, assess the chest pain, we're going to give aspirin, we're going to give nitroglycerin. Any questions? All right, so now we're going to talk about some other important things I just want to highlight for your NCLEX. Okay, I want you to know about the different types of cardiac biomarkers. So this is also important. So guys, I don't want you to feel upset or frustrated if we're moving a little fast. You are going to have to watch the recording again because this is so important to you passing the NCLEX. Remember, if you are strong in cardiac, you're going to pass the NCLEX, okay? Cardiac is the most important topic. It's even more important than dosage calculation because, again, heart disease is the number one cause of death in the world. And if NCLEX wants you to, NCLEX is like a job interview to see if you can be a safe nurse. So, to be a safe nurse, you have to know how to treat what patients most commonly have, which is heart disease. Okay, so the cardiac biomarkers, I want you to memorize this section. I want you to be strong in this section. If you have to make flashcards, make them. So cardiac biomarkers such as CKMB, troponin 1, troponin T, and myoglobin are released into the bloodstream after myocardial cell injury, with troponins being the most sensitive and specific biomarkers. CTN, or cardiac troponin, refers to heart-specific troponins, troponin 1, which is called CTN1, and troponin T, CTNT. I know you're like, what the heck? Okay. But just remember that troponin 1 and troponin T are heart specific cardiac proteins. Okay. Or heart specific proteins. These proteins are released into the bloodstream when myocardial cells are damaged, making them highly sensitive and specific biomarkers for diagnosing acute coronary syndromes and myocardial infarction. High sensitivity troponin assays are advanced blood tests that detect very low levels of cardiac troponins, such as troponin T or troponin 1. Okay. These assays are far more sensitive and precise than older tests, capable of identifying troponin levels as low as 0.003 to 0.006 nanograms per milliliter, which allows for earlier detection of myocardial infarction. Patients with suspected acute coronary syndromes should have troponin levels checked on presentation and repeated every 2 to 3 hours with high sensitivity troponin cardiac troponins, 6 hours with standard assays, with rising levels strongly suggesting acute coronary syndrome, while stable or normal levels indicating another cause. An elevated high sensitive troponin indicates myocardial injury, but not necessarily the cause, so results may be interpreted alongside clinical presentation, risk factors, and EKG findings. So, what is the NCLEX key? The NCLEX key is that high sensitivity troponin, or HSCTN, is now the preferred test for diagnosing acute coronary syndrome because it enables earlier and more accurate detection of MI. With standard assays, troponin is usually measured at 0 and 6 hours, whereas high sensitivity troponin assays allow detection much earlier, often within 2 to 3 hours. Okay, so I want you to go through this as you're studying the recording, and I want you to read this. I want you to take notes or make flashcards and understand this very well. All right, so we have an understanding that just because someone has chest pain, it does not mean that they're having a heart attack. But if they're having chest pain, we do the EKG and it has ST elevation or depression. That is a sign of heart attack. If we do the high sensitivity troponin assays and they are elevated, that is in alignment with a heart attack. So what do we do? What do we do? Immediate nursing priorities: rapid EKG and cardiac monitoring, oxygen if the SpO2 is less than 90, Aspirin, they're going to chew it to prevent blood clot formation and platelet aggregation. Nitroglycerin, sublingual or IV. Beta blockers to help reduce myocardial oxygen demand. Anticoagulants like heparin and enoxaparin to further prevent blood clot formation. Statins to help stabilize the fatty plaque. And at the healthcare provider's discretion, reperfusion therapy. This is the gold standard in treatment. STEMI and STEMI. STEMI, they're going to do PCI, percutaneous coronary intervention, within 90 minutes, or thrombolytics if PCI is unavailable. And STEMI, or unstable angina, medical management with anticoagulants and antiplatelets, followed by percutaneous coronary intervention if indicated. So I know you're like, what is that? So we're going to watch some videos. Can everyone see the screen with the play button? All right.
Coronary artery disease is narrowing of the coronary arteries secondary to several risk factors, some of which are cigarette smoking, hypertension, hyperlipidemia, and diabetes. Percutaneous coronary intervention, or PCI, is a procedure used to treat and evaluate partially and completely occluded coronary vessels. Atherosclerosis results from endothelial injury, inflammation, and accumulation of lipoprotein, leading to intimal deposition of particles and narrowing of the coronary artery. The stenotic vessel makes it difficult for red blood cells to pass through. Therefore, the risk of ischemia and infarction is increased. During a percutaneous coronary intervention, an incision is made to isolate the femoral artery. A catheter is inserted into the artery and guided up the aorta to the heart. Live angiography is used to guide the catheter to the obstructed coronary artery. Radiopaque dye is injected into the artery. Imaging determines the location of the stenosis and the diameter of the vessel. Once the vessel is isolated and the obstruction located, a guide wire is threaded through the catheter to the location. The catheter is removed, leaving the guide wire. A balloon catheter is pushed over the guide wire and centered over the blockage. The balloon is inflated to open the narrowed vessel. The balloon is inflated and deflated multiple times to gradually widen the occluded vessel. To ensure that the artery remains unobstructed, a second balloon catheter with a stent is threaded to the location. The balloon is inflated, expanding the stent. For some patients, drug-eluting stents are used to decrease the chances of in-stent stenosis. Drug-eluting stents are coated with a material that will retard new intimal hyperplasia. Blood flow through the coronary artery is restored.
Coronary arteries are blood vessels that take blood and oxygen to the heart muscle itself. If the blockages are very extensive, involve a lot of areas in the circulation, people may get chest discomfort, chest pains, shortness of breath. My name is Dr. Murat Tuzcu. I'm an interventional cardiologist. I'm the chairman of cardiovascular medicine at the Cleveland Clinic Abu Dhabi. I'm also the chief academic officer. Here I'm very fortunate to work with 4 other interventional cardiologists. Patients should be evaluated carefully. We may choose one of 3 ways. 1, we may treat the patient by medicines and lifestyle changes. Number 2, we may choose to treat the blockages with stents, or if the blockages are very extensive, involve a lot of areas in the circulation, we may choose to perform bypass surgery. If we choose stents, we call that type of treatment PCI, that stands for percutaneous coronary intervention, meaning that we don't make a cut, but work through tiny holes from groin or the wrist and advance a tiny catheter to take pictures of the blood vessels supplying the heart and identify the problem areas. Right here, you see the blood vessel is narrowed by the fatty buildup in the wall. In order to treat this narrowing, we thread a tiny wire across it. Over this wire, we advance a long balloon and place it right across the narrowing. Inflate the balloon that expands the artery. We take the balloon out and we advance a stent mounted on a balloon into the opening right across the obstruction, inflate the balloon, expand the stent, then we deflate the balloon, take the balloon and the wire out. Now we are left with an expanded, opened narrowing. Patient is transferred from the cath lab to the ward and rests the remaining hours of the day. And next day, we check the patient's access site, we check the blood work, we check the EKG, and if everything is okay, most of the time we're able to send the patient home. After going home, we make sure that they take some of the medications very, very religiously, but they will be able to resume their daily activities very shortly. It's critically important. Patient adheres to a healthy diet, regular exercise, maintain an ideal body weight, and takes this medication. Most will agree that the heart disease is probably the most threatening disease that we know of. It doesn't only kill, it also leaves you incapacitated or very limited. That's why I think that the early detection and treatment of heart disease is critically important. We don't want people to have heart attacks. We don't want people to have sudden death. So if they have any symptoms, they should seek medical attention.
I love that video with a passion. Okay, all right, one more.
And they've been very, excuse me. That's a STEMI, so we gotta go. Sorry, guys. When that 911 calls, okay, now what happens?
There is a full appreciation that this is a potentially life-saving intervention.
I mean, there's all kinds of complications that you can have if you have a heart attack that's not treated appropriately.
Our community is supported by very proficient and professional EMS crews that arrive on the scene. They begin to assess the patient immediately, blood pressure, heart rate, O2 saturations.
Deep breath in and out.
We're having our ambulance crews do EKGs in the field, and they're interpreting the EKG, calling the emergency room doc, and the ED doc will make the decision to initiate the team.
Requesting entry note for a STEMI patient going to Beverly Hospital.
STEMI stands for ST segment elevation MI, and that's a specific type of heart attack.
All right, so what do we have, guys? Called us this morning, say he's having crushing chest pain.
Now the Beverly Hospital has the ability to perform an emergency angioplasty. There's no longer any delays involved with delayed recognition in the emergency room or transfer to another hospital. We can actually bring urban level care right to the community, the patient's own neighborhood.
Cath lab's en route.
Well, when you have a heart attack, it's very important that we open up that artery as soon as possible, because as that artery is closed off and the blood supply is choked off to that area, the heart tissue begins to die. The longer that the artery is not supplying blood flow to that muscle, the more tissue that dies.
That's where the emphasis comes to door-to-balloon time, which simply is the time it takes for someone to hit the emergency room door and to go to the cath lab and get a blood vessel open.
Our benchmark is 90 minutes. We're averaging around 60 minutes, some even less than that. So I'm very proud of our team to get those kind of numbers. Our outcomes have been very good. We've been taking care of very sick patients, and they've been discharged from the hospital. We've had some very good outcomes. I'm very pleased with that.
Implementing primary angioplasty was a 5-year journey, and it really demonstrates who we are as an organization. We have clinical advancements in so many other areas, and this particular service was missing.
Left forward, right forward, angled.
We needed to establish a program here at Beverly Hospital, in particular for the Cape Ann region and our primary service area.
Yes.
Paige is just doing STEMI, she's not doing
I'd been working on this program for 3 years, and there were a lot of hurdles to jump through, and there were a lot of barriers here. But one of the catalysts to really getting this program off the ground was the arrival of Dr. Lockery.
This is one of our heart attack patients.
He truly is an educator. He works elbow to elbow with our nursing staff to make sure that the teamwork that is necessary for these types of programs is in place. He works very collaboratively with our other physicians, and he really has an approach that means excellence.
In the lab, we want to make sure that if you listen to lectures across the country about successful cardiovascular programs, they always come down to it's a multidisciplinary approach.
In fact, in recognition of that, Beverly Hospital has created a cardiovascular department which has representation from vascular surgeons, radiologists, cardiologists, and we all sort of work together.
The EKG was at 3:47 a.m. There are so many different parts to this puzzle. But everybody's chipping in. What I like to say is, this is not one person's program, it's our program. It truly is our program. And that's evidenced by the fact of the successes there because of everybody's involvement.
You gotta be careful creating two different processes.
In the state of Massachusetts, you start with emergency angioplasty. If our volume and our numbers look good, at some point we'll get to move to elective angioplasty, which really broadens our scope of practice.
It goes through your body, goes right into the heart blood vessel.
The benefit of offering more than just cardiac catheterization allows us to have patients come to our facility and be taken care of. And because we hang on to those patients and they know they can get good care here, they're more confident in us, that elevates our cardiology division. Then what happens is that patient stays in the system, the other services are required to take care of that patient, and the whole hospital benefits. So this STEMI program is a nidus, if you will, or a template to build the division, to build the hospital, and recognize that we can come to Beverly and have good cardiovascular care. That's our goal, and that's our main focus.
Okay, and I just have one more thing I want to show you. Hold on.
For these types of programs is in place. He works necessary for these.
So this picture, it kind of shows you, but you see how the doctor's working with the nurses? That's going to be you guys one day. Ah! I believe that for you, so don't give up. So you're learning all of this. So everything that you're learning, you know, from the study guide, when you come to lecture, when you do the PowerPoints when you're studying, it's also because you're going to be part of a team. And it's also because, let me show you this picture right quick. Hold on. So you're learning all this so you can do that in real time. And guess what? I keep messing up. Hold on. I'm going to fix it. Watch it. Hold on. I believe in myself.
There is a full appreciation that this is.
Okay, I should not get a career in editing videos, apparently, because I didn't make this, but hold on. Because this guy, this patient is depending on you, right? To show up and know what you're doing and know what to recognize. His family is depending on you, right? So there's going to be situations where he could be afraid and terrified, and he's depending on you to know what is going on with him and to know how to treat him properly. And guess what? Your team workers, your co-workers, they're depending on you to know what you're doing and to help take care of the patient and make the process a smooth process, an intercollaborative process, okay? So This is what nursing is all about. And so I love these videos because it really puts it into perspective. It's more than just NCLEX questions on a screen. It's really preparing you for the real world. All right. So let's talk about cardiac catheterization and percutaneous coronary intervention. Just give me a few seconds. All right, so cardiac catheterization, break the word down. Cardiac, we're focused on the heart. Catheterization, we're using a catheter. So just like the doctor said in the video, they can do the radial or they can do the femoral, like the groin. So they can go in through the wrist or they can go in through the groin. So when I was in nursing school, it was like really popular, like all the groin, and then they found out you can also go through the wrist and whatever, right? But we usually talk about the groin more because the risk for bleeding is so much greater because the access point, that artery that they're using to first access, is so large and in such a inconvenient location for what has to happen afterwards, okay? So cardiac catheterization, write this down. Cardiac catheterization, the nursing responsibility is greatest after the procedure. I mean, all throughout, the patient is your patient, you're helping them, you're taking care of them, you're monitoring them for stability, airway, breathing, circulation, vital signs, all of that. But truly, the highest risk for the patient to bleed to death is after cardiac cath, but you do have responsibilities before, okay? So your major responsibilities for cardiac catheterization as a nurse. Number one, to assess patient for allergies. Why? Because for cardiac catheterization, in order for them to visualize the arteries on the screen, they're going to inject contrast dye into the IV. Okay, so we have to assess for allergies to what? Shellfish, iodine, and radiopaque dye, right? If they're on metformin, we hold it 24 hours before, 48 hours after. We also need an accurate height and weight to make sure we administer the right amount of contrast dye. Okay. They insert the catheter into the insertion site. As you can see, they go up and through the aortic arch, and they're going to access the coronary arteries. You see? The healthcare provider will access the coronary arteries. They will inject dye into the vessels, and they're going to get a fluoroscopic image. A fluoroscopic image, it looks like an X-ray movie, okay? And wherever they see like a pinching, or that's a narrowing, okay? So wherever they see this, there is a blockage, okay? Does that make sense? Very good. Okay. So we talked about cardiac cath. Once they're there and they have identified a blockage, they can intervene. So write this down. A cardiac cath can be diagnostic and it can be interventional. So you can use a cardiac cath, or the healthcare provider can use a cardiac cath to diagnose coronary artery disease. This is coronary artery disease. It's narrowing because that's the lumen size. That little skinny part, that's the only space available for red blood cells to go and perfuse the tissues, because everything else, let me get my pencil. This is all fat. You see what I'm saying? So Cardiac cath can be diagnostic, and then once they have diagnosed the problem and decided that they can move forward in treating it, then it will switch to interventional, if it's appropriate, interventional. Then once it's interventional, they're going to do angioplasty. Okay, so make sure you wrote that down. Cardiac cath can be diagnostic, where they diagnose a problem like coronary artery disease. Then at the healthcare provider's discretion, it's their clinical judgment whether they're going to intervene, because sometimes the blood vessels may not be amenable to angioplasty. Okay, once it switches to interventional and they decide to do something, one of the options is angioplasty. What does angio mean? Angio means blood vessel. And what does plasty mean? Plasty, P-L-A-S-T-Y. To fix, okay? So angioplasty literally means to fix a blood vessel. So as you can see in the first picture, we have the plaque reducing the lumen size of that coronary artery. The healthcare provider through the catheter will filter through the balloon, expand the balloon, and increase the lumen size of the artery. And then they can choose to follow up with a stent. Okay, and they usually do, because the risk of vascular recoil, if they just do the balloon, the risk of vascular recoil where it would just like the fat would just like kind of in a way like pop back into place, the risk of vascular recoil is high. So that's why they usually put a stent. And they can be just a plain stent, which is called a bare metal stent, or it can have like medication like laced into it, and it's called a drug eluting stent that will like slowly release like an anticoagulant or antithrombotic medication. Okay, this is what we call percutaneous coronary intervention. So write that down and write it next to the notes where you put cardiac cath can be diagnostic and it could be interventional. If it's interventional, they will do angioplasty, which is considered percutaneous coronary intervention. And the goal from when it is identified that the patient has a STEMI to the balloon being inflated is 90 minutes. That's the golden standard. They call it like, STEMI to balloon time. The goal is to have it within 90 minutes from when they step foot in the ED to when the doctor is inflating the balloon in the patient's artery. Okay. After cardiac cath, your number one priority is to make sure that the insertion site doesn't bleed. So I want you for homework to read the section where it said, we're on cardiac cath in Module 5 study guide. Read that section, know it very well. You have to be strong in that section if you want to pass the NCLEX. Your main nursing priorities are after the cardiac cath, because you want to make sure that the patient keeps that extremity straight for 6 to 12 hours. So I have a question for you. If your patient had a cardiac cath through the groin, can they get up and go to the bathroom after cardiac cath? Very good. So they are on bed rest. Okay, we don't want them bending that leg because we're going to put a pressure dressing over the site and we don't want the pressure dressing to come off. Okay, It's called a FemStop. I'm going to put the picture up for you. Give me a moment. It's so many slides, that's why. So I have a question for you. What can we do if after cardiac cath, if the patient has to use the bathroom? We don't want them bending, but can we turn them side to side? Very good. We can turn them side to side. Okay. So this is a FemStop, or it says like female stop, but we say FemStop because like femoral artery, they went in through the groin. And this is what it looks like when it's on the patient. And it has like a blood pressure cuff. And we're going to wrap it around the patient's hips or place it on them. And then when we close it, we're going to close it. And then we're going to use like the bulb and like press on it, and it presses down and it applies pressure on the insertion site so the patient doesn't bleed. Okay, the belt wraps around the patient for support. This is the pneumatic bubble, and it's inflated over the arterial entry site, which is called the arteriotomy, to compress the artery during and after sheath removal. And so we want the patient for 6 to 12 hours to keep that extremity straight. If they have to go to the bathroom, we can turn them side to side and use a bedpan. If it's a male, give them a urinal if they have to use the bathroom. And we're going to monitor for bleeding. NCLEX, after cardiac cath, if you see any bruising on the extremity that indicates bleeding, we want to apply pressure and call the healthcare provider. Any bleeding, we're going to apply pressure and call the healthcare provider. Those are medical emergencies, okay? Any questions, guys? I know we went through a lot right now and it was brutal. And while you're trying to figure out if you have any questions, this is another picture of cardiac cath, them going through the femoral site. And then here we have the fluoroscopic image of an artery. And so wherever they see narrowing, you know, that indicates blockages. Okay. Here's another picture of percutaneous coronary intervention. Some people call it percutaneous transluminal coronary angioplasty, but percutaneous coronary intervention, that is perfect to memorize for NCLEX. And I feel that you have a good understanding of it. Okay, now, so anyways, if there are multiple blockages or the blockage is severe to the point where just a balloon and a stent won't be sufficient enough, that area, there's just no way we can reperfuse the area, because do we understand that the goal in doing the percutaneous coronary intervention, the goal is to establish reperfusion? Does that make sense? The goal of percutaneous coronary intervention is to establish reperfusion. To establish perfusion, right? Does that make sense? Okay. Let's say that that is not possible because of the anatomy, the severity of the blockage. they're going to have to bypass the blockage. They're like, you know what, forget it. We can't fix the blockage. We cannot perform angioplasty that is effective in establishing perfusion. So we're going to bypass the whole thing. And so that is what we call a coronary artery bypass graft, or a CABG. CABG is when we bypass a severely blocked coronary artery with a graft placed above and below the blockage. So let's say here is the blockage, here's the area of decreased blood flow, and when they do the cardiac cath, they can visualize the blockage, and the healthcare provider makes the clinical judgment that this artery is not amenable for percutaneous coronary intervention. Maybe the balloon and stenting will not be effective or enough. Then they will take a graft, they will take an artery or a blood vessel from another site, and they will place it above the blockage and below it so that oxygenated blood can reach the area that is not properly perfused. Okay. There's another picture I just wanted to show you. And then here you can have single bypass, double bypass, triple bypass, quadruple bypass. I mean, this patient needs some lifestyle choice education. All right, guys, we are making really, really wonderful progress. Let's take a 5-minute break, and when we come back, we're going to finish up cardiac. You guys are doing excellent. Thank you very much. All right, guys. So now we're going to finish up cardiac, hitting on the most important topics that you have to understand and most important medications. First up is congestive heart failure, just understanding the symptoms. Understanding the symptoms and medications are the most important aspects for you to successfully answer questions on this disease. So the symptoms of right-sided heart failure, think rest of body. Left-sided heart failure, think left lungs. Okay, so the symptoms of right-sided heart failure, the blood is going to back up to where the rest of the body. So that's where you're going to get jugular vein distension, edema, ascites, which is fluid in the belly, enlarged liver and spleen, anorexia, weight gain, and swelling of fingers and hands, and increased blood pressure. The symptoms of left-sided heart failure are more like lung-related, so pulmonary congestion, shortness of breath, crackles, dry hacking cough, and also both of them you're going to experience increases in blood pressure because congestive heart failure is associated with fluid retention because the heart fails to work as a pump. Okay, and so instead of pumping blood to where it should go, in heart failure, blood ends up backing up to where it came from, leading to fluid retention and these symptoms we see here. Medications to know for NCLEX, congestive heart failure, digoxin and diuretics. Okay, so write that down, digoxin and diuretics. So how does digoxin help in the treatment of heart failure? Digoxin makes the heart contract more effectively. Before giving digoxin, you want to check the heart rate and hold if it's less than 60. You also want to check the potassium and hold if it's less than 3.5 to avoid digoxin toxicity. So digoxin, you check the heart rate and the potassium. If either of them are low, call the healthcare provider. Diuretics, they help with fluid balance. So you've got loop diuretics and potassium sparing. Loop diuretics like furosemide drop potassium, so check the potassium level. Potassium sparing diuretics, they increase potassium level, so you would want to check potassium level regardless. Interventions for CHF, fluid restriction, and a low sodium diet, because remember, water follows salt. So if a patient with heart failure eats a high sodium diet, they're going to retain more fluid and increase their fluid volume and increase the burden or workload on the heart. We also want to do daily weights, monitoring for fluid overload. If they gain 2 to 3 pounds in one day, that's considered fluid overload. Weigh them in the morning after the patient voids. Weigh them at the same time each day, and it would be best to weigh them on the same scale. Alternate between activity and rest because they will get tired, so give them rest periods and elevate their legs to help with swelling. Next up, we're talking about valve problems. So, and again, I know we're zooming through this, but these are important concepts to understand, and you will find them in the recording to play back as many times as you need. Valve problems. You have stenosis and you have regurgitation. So when we're talking about stenosis, I underline the NO and I think no open. In valve stenosis, the valve won't open. Regurgitation, the valve won't close and blood regurgitates back to where it came from. Please memorize that. So here we have a picture showing aortic stenosis. So aortic stenosis, remember, NO, no open. So here we have in a normal heart, when the aortic valve opens, it lets that fresh oxygenated blood from the left ventricle enter and go into the aorta and the coronary arteries, and everyone is super happy. But in aortic stenosis, we can see here there's calcification, and this is years and years of wear and tear and abuse. And also, it doesn't open all the way. You can see how much this valve opens here, and you can see only a little bit opens. So the patient is not going to receive as much oxygenated blood into the systemic circulation as they should. And years of this setup, and it is probably due to hypertension. We can see a change in the size of the muscle. So look at this picture. You can see the left ventricle muscle, and then we can see here there's some hypertrophy, and that's from years and years of the heart being overworked. And why is the heart being overworked? Because the heart has to push as much as it can to only get a little bit of blood out. You see what I'm saying? So whereas a normal contraction here is going to bring a normal expected amount of cardiac output out of the heart, here the body's not receiving enough oxygenated blood, and this puts an increased strain on the heart, and the heart is either trying to beat faster or with more force. And years of beating at a higher force has caused the muscle to grow hypertrophy. And I know you're like, well, that's great. The size of the muscle is bigger, so the heart can work harder. Unfortunately, as the size of the muscle grows, the size of the chamber decreases. Right? So whereas we had more room here for fresh oxygenated blood to sit and then go into the aorta, now we have less room. So we have less room to receive oxygenated blood, and the door for it to get out of the heart is smaller. Okay? So overall, this is a very stressful situation for the heart that is not compatible with a positive outcome for the patient. So they can do a surgery like an aortic valve replacement. Okay? Here we have a graphic of a normal aortic valve opening and closing. And then we have a diseased stenotic valve. Okay? This is a stenotic aortic valve. So you can see the difference. This valve has had a hard life, okay? Options, they can do a valve repair, like a balloon valvuloplasty. So they would enter the heart kind of like the same way they would a cardiac cath. So if they do a cardiac cath to fix something in the heart, whether it's angioplasty or valvuloplasty to fix a valve, that's what we call closed heart surgery. Okay, when they have to open up the chest, that's open heart surgery, right? So like to do a CABG, they would do open heart surgery. To do like an angioplasty or valvuloplasty, they would do like cardiac cath, right? So they can either do a valve repair where they try to repair the valve, or if the valve just cannot be repaired, they would do a valve replacement. And your number one concern for these is increased risk for stroke. Please memorize that. The number one concern with valve replacement is increased risk for stroke. So a common NCLEX scenario you might see is a client with aortic stenosis is scheduled for surgery in 2 weeks. The client reports episodes of angina and passing out twice at home. Which would be the best nurse explanation for the appropriate activity at this time? The best answer would be, if it's for aortic stenosis, is to avoid strenuous activity before the surgery. Okay? So any question about aortic stenosis pre-op, the best advice to give the patient is to avoid strenuous activity before the surgery. Then we have mitral valve regurgitation. So in stenosis, it won't open. In regurgitation, it won't close. So let's look at a healthy heart. So remember, your valves are in between the chambers, right? And so they're either in between the chambers or in between a chamber and another vessel. So here we see the tricuspid valve, it's opening and blood is moving forward. The pulmonic valve, blood is opening and moving forward, right? The mitral or bicuspid valve, it opens, closes, and blood is moving forward. So just as it's important for a valve to open, it's also equally important for the valve to close once the blood is inside where it needs to go, okay? Because if it doesn't close, it's going to back up. So let's take a look and see. So because this is a mitral valve problem, look at the mitral valve. It's not closing, and blood that is oxygenated, it enters the left ventricle and goes back up to the left atria. So this is what we call mitral valve regurgitation. Okay, so a common treatment is a mitral valve replacement, and there are two types, tissue or mechanical. The number one priority for mechanical heart valve replacement is that the patient must be on anticoagulants for life. So the way that you can memorize that is, I think mechanical, I think robotic, mechanical, robotic, and I think if you have a mechanical heart valve, you have to take the anticoagulants like a robot for the rest of your life. Like no thinking about it, you just have to do it. Okay? So please memorize that for NCLEX. The number one priority for mechanical heart valve replacement is that the patient must be on anticoagulants for life. All right, pericarditis. Pericarditis. The pericardium is like a purse that's around the heart. It's like a sac that holds the heart. So here we have a normal pericardium here, and then we have pericarditis where we have inflammation. You see? This is going to make it difficult for the heart to open, because when the heart contracts or beats, it's squeezing so it gets smaller. But when the heart relaxes, it expands, so allow the filling, to allow blood to enter, right? Blood has to enter and then it squeezes to get let out. It enters and then it squeezes to get let out. So pericarditis is going to affect the heart's ability to open and receive blood. So if it can't receive blood, not enough blood is going to leave, right? So what is it? The outer sac that surrounds the heart becomes inflamed. Assessment, it's chest pain that gets worse when they lay down or breathe. Interventions, put them in high Fowler's leaning forward, oxygen, pain medication, blood culture, antibiotics, and steroids. Okay? Review that. Endocarditis. I want you to know the number one issue here is valves. Valves. Okay? Endocarditis is the inflammation of the inner lining of the heart, especially at the valves. I'm going to say it again. A major issue with endocarditis is the valves. A major concept for you to memorize is that endocarditis is common in IV drug abusers and those who recently had dental work. The problem is that vegetations grow on the valves from infection, and it can break off and cause stroke, heart attack, or PE. Assessment for endocarditis: fever, weight loss, fatigue, Janeway lesions, Osler nodes. Treatment: IV antibiotics. Outlook: anytime they're going to have any dental procedure, they need to be on prophylactic antibiotics. Endocarditis is extremely important. Please study this slide and know it well. What are the difference between Osler's nodes and Janeway lesions in endocarditis? Osler's nodes are painful. So I think Osler's equals ouch. So they both kind of look the same, but Osler nodes are painful. Okay, so Osler nodes are painful and tender. Janeway lesions are not tender. They're not painful. So the big takeaways for endocarditis is it's common in IV drug abusers. Anything about dental work, that's a sign. And they're going to be on IV antibiotics. It can cause valve problems, and it could lead to heart attack, stroke, and PE. The treatments, make sure you know them very well, okay? IV antibiotics for weeks or months, okay? Let me see something. All right, we just have a few more left, but I feel bad because again, I don't like to rush through things. So it won't take us long next class to finish those up. So don't worry about that. But you guys did really good. You have a lot to review. So please, please, please make sure you make it your priority to review the recording once I post it. Make sure you read the section on cardiac cath in the study guide. And I do believe that you will pass the next time you go. All right, guys. So I will see you next week. Don't forget, let me double check my calendar to make sure I'm giving you the right date. Okay, don't forget we don't have class Monday, October 27th. So we have class on the 20th, but we're not having class on the 27th. And so we'll just add on an extra week to that, okay? But we're making very good progress and you're learning what you have to learn so that you can be successful the next time you go on the NCLEX. All right, guys, thank you and please have a wonderful day and God bless you. Remember, you're going to make it. Bye-bye.